Erythematosus. This is a chronic Systemic lupus erythematosus. This is a chronic multi-system autoimmune disease, commonest in young 9, especially in pregnancy. It is characterized by the presence of numerous antibodies, including antinuclear antibody, and immune-mediated tissue damage. Preoperative assessment, skin and joint involvement is common, as are oral and pharyngeal ulcerations, CVS. Pericarditis in 15% of cases. Myocarditis, endocarditis and conduction abnormalities are less common. Raynaud's phenomenon 30%. CAD, respiratory, infections and PEs common. Pleuritis and pleural effusion, pulmonary fibrosis less common. Neurological, cranial and peripheral nerve lesions may occur 2 degrees to arteritis and ischemia. Transverse myelitis, leading to weakness or paraplegia, is rare. Depression, psychosis and seizures are possible. Renal, glomerulonephritis, which may lead to nephrotic syndrome and renal failure. Hematological, cytopenias, clotting disorders or hypercoagulable states can occur. Immune thrombocytopenia or circulating anticoagulants e.g., antibodies to factor VILI, may be present. Up to a third of patients with SLE may demonstrate features of antiphospholipid syndrome. Higher risk of CVE with antiphospholipid antibodies, steroids and other immunosuppressant drugs are used. Anesthesia. There may be absolute or relative contraindications to neuraxle blocks in patients taking anticoagulants or in patients with coagulopathy. The presence of a peripheral nerve lesion may be a relative contraindication to neuraxle regional nerve blockade. Maintenance of normothermia may reduce the risk of infection, as well as lessening the impact of Raynaud's phenomenon. If present, laryngeal erythema and edema are common. Try to minimize trauma to the airway. Consider hourly urine output and invasive monitoring, steroid supplementation, strict asepsis with invasive procedures. As increased risk of infection, perioperative VTE prophylaxis, achondroplasia. The commonest form of dwarfism is caused by premature ossification of bones, combined with normal periosteal bone formation, giving a characteristic appearance of short limbs and a relatively normal cranium. The following should be noted: large head and tongue, midfacial hypoplasia, obesity and small larynx may lead to difficulties managing the airway. Laryngoscopy may additionally be compromised by pectus carinatum. Foramen magnum stenosis is common. Avoid hyperextension during intubation. Central and peripheral venous access is often difficult. Use an appropriately sized BP cuff. Xerosay is common. Restrictive ventilatory defects may occur and can lead to pulmonary hypertension. Regional techniques may be difficult. The back may be normal. The epidural space is often narrowed with spinal canal stenosis. The volume of LA needed for a subarachnoid and epidural block is reduced. Epidural over spinal anesthesia may be preferred due to ability to titrate to desired height. The patient is of normal intelligence. Hematology, porphyria. The porphyrias are a group of diseases in which there is an enzyme defect in the synthesis of the heme moiety, leading to an accumulation of precursors that are oxidized into porphyrins. There are hepatic and erythropoietic varieties. There are 8 different forms of porphyria. There are 3 autosomal dominant acute hepatic forms, with typically 50% reduction in usual enzyme activity, that affect the administration of anesthesia. Acute intermittent porphyria, the commonest and most severe form of acute porphyria. Common in Sweden. Increased urinary porphobilinogen and deaminolevulinic acid, variegate porphyria, common in Afrikaners icopra and protoporphyrin in the stool. Dermal photosensitivity, hereditary coproporphyria, very rare urinary porphyrins. Dermal photosensitivity, porphyric crises. Attacks occur most frequently in women in the 3rd to 4th decades. 50% of normal enzyme activity is usually enough to maintain hemostasis. Increased demand for heme increases flow-through pathway and increases aminolevulinic acid and porphyrin production, leading to symptoms. Factors increasing heme demand, including hemorrhage, induction of P450 enzymes, stress and dehydration, should be avoided. Acute porphyric crises may be precipitated by drugs, stress, infection, alcohol, menstruation, pregnancy. Starvation and dehydration. Symptoms include acute abdominal pain, vomiting, motor and sensory peripheral, neuropathy, autonomic dysfunction, cranial nerve palsies, mental disturbances, coma, convulsions and pyrexia. General principles. Patients may never have had an attack, therefore, a positive family history must be taken seriously. Individuals may have normal biochemical tests between attacks. Patients may present with unrelated pathology, e.g., appendicitis. Symptoms may mimic surgical pathologies, e.g., acute abdominal pain, acute neurology. Any patient giving a strong family history of porphyria must be treated as potentially at risk. Latent carriers may exhibit no signs and be potentially negative to biochemical screening, but still be at risk from acute attacks. Anesthetic management. Many commonly used drugs are thought to have the potential to trigger porphyric crises. However, it is difficult to be definitive, as crises can also be triggered by infection or stress, which often occur simultaneously. Table 11.1 lists the relative safety of commonly used anesthetic drugs in patients with porphyria. It is important to minimize stress, so consider premedication with midazolam. Minimize preoperative fasting. Use 5% glucose 0.9% sodium chloride IV. Regional anesthesia is useful, but in acute porphyric crises, regional anesthesia should be avoided as neuropathy may be rapid in onset and progressive. Detailed preoperative examination and documentation of any neuropathy are essential. Bupivacaine is considered safe for epidural anesthesia. PONV prophylaxis is especially recommended. As prolonged starvation time can be contributory to porphyric crises, measure BP invasively during an acute crisis, as hypovolemia is common and autonomic neuropathy may cause labile BP. Once common causes e.g., pain, light anesthesia are ruled out. Hypertension and tachycardia should be treated promptly with B blockers such as metoprolol. Treat seizures with diazepam, propofol or magnesium sulfate. Avoid barbiturates and phenytoin. Manage the patient on IQHDU if a crisis is suspected. Remember that the onset of a porphyric crisis may be delayed for up to 5D. Table 11.1 Anesthetic drugs in porphyria, not porphyrinogenic. Propofol, probably safe, probably or possibly porphyrinogenic. Ketamine, etomidate, dexamethasone, porphyrinogenic. Thiopental halothane, anesthetic. Agents, sevoflurane, flumezanol, morphine, pethidine, dexmedetomidine, EEES, amiodarone, methyldopahydralazine, clarithromycin, hydrocortisone, prednisone. Monitor the patient appropriately. Hemostatic drug therapy, tranexam. Treatment of acute porphyric crises. Withdraw drugs that may have precipitated the crisis. Give Hemargin at 3 mg/kg IV once daily for 40. Leads to negative feedback to aminolevulinic acid synthetase, the initial enzyme responsible for heme production. Treat infection, dehydration and electrolyte imbalance, and give glucose, 20 gh. Treat symptoms with safe drugs, e.e., local anesthetics. The patient appropriately. Hemostatic drug therapy, tranexamic acid. 1. Mechanism. Tranexamic acid binds to plasminogen, preventing its conversion to plasmin and subsequent fibrin degradation. 2. Indications: significant bleeding due to trauma, traumatic brain injury, surgical blood loss e.g., orthopedic, cardiac, and craniofacial surgery, menstrual bleeding, menorrhagia, reversal of thrombolytic drugs. 3. Dosage: trauma. 1 gram v over 10 minutes, followed by 1 gram over 8h, surgical bleeding. 1 gram IV or 10-20 mg/kg before incision, plus or minus second dose of 0.5-1 gram IV postoperatively, menorrhagia. 1 gram TDSPO. 4. Contraindications: renal failure, epilepsy, certain gynecological procedures e.g., myomectomy, acute VTE, DIC without significant bleeding. 5. Important, no increased risk of vaso-occlusive events observed in clinical trials. Desmopressin. Desmopressin is an analog of arginine vasopressin that induces the release of von Willebrand factor, VWF, from the vascular endothelium, increasing both VWF and factor VILO levels. 1. Mechanism: increases VWF and factor VILO levels by inducing release from vascular endothelium. 2. Indications: hemophilia A and von Willebrand's disease, platelet dysfunction and renal failure, aspirin-induced platelet dysfunction. 3. Dosage: 0.3 micrograms kg/IV in 50-100 milliliters, 0.9% sodium chloride over 13 min. 4. Effect: doubles or quadruples VWF and factor VIII levels, improving hemostasis. Recombinant factor VLA, RFVILA. 1. Mechanism: acts at the tissue factor VILA complex at the site of endothelial damage. 2. Indications: licensed for hemophilia with inhibitory alloantibodies and congenital factor VIL deficiency. 3. Off-label use: has been used to control bleeding in various situations, but evidence is weak, and thrombogenic risk is a concern. 4. Dosage: 20-40 micrograms kg/IV, but dosing and delivery mode are not established. Prothrombin complex concentrates PCC. 1. Composition: contains factors Li, 7, 9, and X. 2. Indications: treatment and prophylaxis of congenital or acquired deficiency of these factors, e.g., during warfarin treatment. 3. Contraindications: angina, recent MI, and history of HIT. 4. Side effects: thrombosis and hypersensitivity, including anaphylaxis, hypercoagulability syndromes, polycythemia, a pattern of RBC changes that usually results in HB, 17.5 GDL in AN, 15.5 GDL in 9. This is accompanied by a corresponding increase in the red cell count to 6.0 and 5.5 x 1012/L in N, HCT of 55% and 47%, respectively. Causes: 1. Polycythemia vera PV, 2 degrees, due to compensatory erythropoietin EPO increase. High altitude, cardiorespiratory diseases, especially cyanotic, heavy smoking, methemoglobinemia, or inappropriate EP0 increase, renal diseases, hydronephrosis, cysts, carcinoma, massive uterine fibromyalgia, hepatocellular carcinoma, cerebellar hemangioblastoma, relative, stress or spurious polycythemia, dehydration or vomiting, plasma loss, burns, enteropathy, polycythemia vera. Presenting features include headaches, dyspnea, chest pain, vertigo, pruritus, epigastric pain, hypertension, gout and thrombotic episodes, particularly retinal. Splenomegaly is typical. Thrombocythemia occurs in 50% of cases. Differential diagnosis is with other causes of polycythemia. These can be excluded by history, examination and blood tests, including bone marrow aspiration, ABGS and EPO levels. Genetic testing can reveal the JAK2 mutation in 90 to 95% of patients with PV, and in 50% of patients with myelofibrosis. Therapy is aimed at maintaining a normal blood count by venesection and myelosuppression with drugs. Thrombosis is a potential cause of death, and 10% of cases develop myelofibrosis and rarely acute leukemia, essential thrombocythemia. Megakaryocyte proliferation and overproduction of platelets are the dominant features, with a sustained platelet count, 450 x 109/L, closely related to PV, with recurrent hemorrhage and thrombosis as the principal clinical features. Abnormal large platelets or megakaryocyte fragments may be seen on a blood film. Differential diagnosis is from other causes of a raised platelet count, e.g., hemorrhage, chronic infection, malignancy, PV, myelosclerosis and chronic granulocytic leukemia. Platelet function tests are consistently abnormal. Hydroxycarbamide is the mainstay of therapy, but some treatments are more toxic. Antiphospholipid syndrome (APS). Antiphospholipid syndrome is a condition characterized by thrombosis, recurrent miscarriage, and the presence of antiphospholipid antibodies. 1. Thrombosis, arterial or venous thrombosis, or recurrent miscarriage. 2. Antiphospholipid antibodies, positive laboratory test for antiphospholipid antibody and/or lupus anticoagulant. 3. Association with autoimmune diseases, may present with SLE secondary APs or as a primary disease. Clinical presentation. 1. Thrombotic events, range from subacute migraine and visual disturbances to major cardiovascular events. 2. Recurrent miscarriage, a common feature in affected individuals. Management. 1. Aspirin, initial treatment for patients without a history of thrombosis. 2. Warfarin, lifelong anticoagulation after a confirmed episode of thrombosis. 3. Perioperative management, IV heparin is often used pre- and postoperatively when warfarin is stopped for surgery due to high thrombosis risk. Epilepsy. Oxford plus Julian Barker, you are asked to anesthetize a 50-year-old male for an elective open cholecystectomy. On your preoperative visit, you discover he is a known epileptic. Tell me about epilepsy. Epilepsy is characterized by a predisposition of the brain to generate abnormal, synchronous neuronal activity. Defined as 2 or more unprovoked epileptic seizures, the quoted incidence of active epilepsy in the community varies. Approximately 9% of people will have at least one seizure in their lifetime and 3% will be given the diagnosis of epilepsy at some point. Males have a greater incidence of epilepsy than females. Do you know any classification syndromes for epilepsy? Has this changed recently? The International League Against Epilepsy (ILE) first published their classification of epilepsy in 1981 and then updated it in 1989. They have recently proposed a revised diagnostic approach and classification syndrome. Description of epilepsy is based on 5 parts or axes. 1. Ictal phenomenology. 2. Seizure type, e.g., self-limiting or continuous, generalized or focal. 3. Syndrome. Diagnosis of known epilepsy syndromes if possible. 4. Etiology, if known. 5. Impairment. What side effects are associated with anti-epileptic drugs? Common side effects to most of these drugs include sedation, somnolence, fatigue and weight changes. There are more specific blood dyscrasias and abnormalities associated with certain agents: blood abnormality, hyponatremia, abnormal LFTs, anemia, thrombocytopenia, leukopenia. Drugs: carbamazepine. Carbamazepine, sodium valproate, phenytoin, phenobarbital, vigabatrin, carbamazepine, sod valproate, primidone, ethosuximide, carbamazepine, primidone. What are the implications of anesthetic drugs in this patient? There are 2 major implications of the use of various anesthetic agents: proconvulsant and anticonvulsant properties of anesthetic agents. Many agents have both pro and anticonvulsant properties. Intravenous induction agents may cause excitatory phenomena, while also having anticonvulsant properties. Etomidate may produce EEG changes and prolong the seizure duration during ECT compared to propofol. Case reports of seizures after etomidate have been published. Propofol may cause excitatory movements, but is thought to be safe in epilepsy. Some anesthetists still avoid its use in epilepsy, especially if driving restrictions may result from possible seizures. Thiopentone is a potent anticonvulsant despite excitatory phenomena at induction. Regarding volatile agents, seizures have been reported following enflurane and EEG changes, may be seen many hours after administration. Neuromuscular blocking drugs have theoretical implications as the breakdown product of atracurium, laudanazine, is proconvulsant in high concentrations in dogs, but does not appear to be a clinical problem in humans. Other agents include ketamine, which may cause excitatory phenomena, but produces EEG suppression and has been used to treat status epilepticus, and benzodiazepines have clear anticonvulsant properties. Interaction between anesthetic agents and antiepileptic medication. Many of the antiepileptic medications have a sedative action on patients. Some of the drugs cause enzyme induction: phenytoin, carbamazepine, primidone, and barbiturates, while others may cause enzyme inhibition. How would you anesthetize this patient? The key consideration is the limitation of seizure activity in the perioperative period. Preoperative assessment for patients with epilepsy. Key considerations. 1. Record seizure nature, timing, and frequency. 2. Document anti-epileptic drug history and timing. 3. Assess associated medical conditions. 4. Consult specialist if seizure control is suboptimal or delayed return to therapy expected. VV preoperative management. 1. Ensure well-controlled epilepsy preoperatively. 2. Continue anti-epileptic medication perioperatively, oral to parenteral if needed. 3. Monitor incorrect urea and electrolyte levels. 4. Consider full blood count if hematopoietic side effects are possible. 5. Benzodiazepine premedication may be considered. Anesthetic management for epilepsy surgery. Induction. 1. Standard ASA1, 2. Monitoring and preoxygenation. 2. IV induction with opioid, fentanyl, thiopentone, and neuromuscular blockade, atracurium. 3. Endotracheal intubation and ventilation, maintenance. 1. Volatile agent maintenance except enflurane. 2. Positive pressure ventilation with normocapnia. 3. Monitor for seizure activity, movement, pupil changes, autonomic activity. 4. Manage seizures with IV benzodiazepines, first line, or IV sodium valproate phenytoin, second line. Emergence and postoperative care. 1. Reversal of neuromuscular blockade and awake extubation. Delayed emergence may be due to unidentified seizure. 2. Early reintroduction of antiepileptic medication. 3. Suitable pain relief, systemic opioids, morphine, or patient-controlled morphine infusion. Key considerations. 1. Perioperative antiepileptic drug management. 2. Monitor electrolyte and glucose levels. 3. Standard ASA monitoring and preoxygenation. 4. Choice of induction agent, thiopentone or propofol, anticonvulsant properties. 5. Regional anesthesia. Minimize disruption of antiepileptic drug regimes, but beware of local anesthetic toxicity. What if oral or nasogastric therapy is not possible? Phenytoin, sodium valproate and levetiracetam can be given IV at equivalent doses to the oral formulation, and carbamazepine can be given rectally. Hypoalbuminemia, acid-base derangement and concomitant drug administration can markedly affect the antiepileptic drug levels. Advice from a pharmacist and measurement of drug levels in the critically ill is very helpful. Postoperative care. Ensure antiepileptic therapy is reinstated as soon as possible. Abnormal movements in the postoperative period may not be due to epilepsy. Look for other causes of seizure abnormal movement. The consequences of a postoperative seizure for some patients will be significant. Status epilepticus algorithm, APLS, advanced pediatric life support, assess based on ABC approach. 1. Assess airway, give oxygen, check glucose. 2. First line treatment, benzodiazepine. 3. Gain vascular access in up to 5 minutes allowed to gain vascular access. 4. Alternative routes if vascular access fails, A. Rectal diazepam, 0.5 mg/kg, B. Buccal midazolam, 0.1 mg/kg, V. Allow 10 minutes for benzodiazepines to work. 5. Second-line treatment. If seizure continues, call for senior help. If seizure activity continues after benzodiazepine administration, A. Phenytoin 20 mg/kg IV/I0, or phenobarbital if already on phenytoin. B. If seizure persists beyond 20 minutes after second-line treatment, perform RSI with thiopentone. Anesthetist's presence required. Parkinson's disease. General considerations. Parkinson's disease (PD) is a multi-system neurological disorder characterized by triad of muscle rigidity, bradykinesia and a resting tremor. Pathophysiology. Loss of dopaminergic neurons in the substantia nigra of the basal ganglia results in a dopamine deficiency and excessive thalamic inhibition. This leads to the classical symptoms seen. Incidence. The disease affects those aged over 65, and is associated with an increased risk of perioperative morbidity and mortality. Prognosis. The disease is incurable and progress cannot be slowed. Treatment is aimed at relieving symptoms with either medication or surgical interventions such as insertion of a deep brain stimulator. Drug therapies. The goal of drug therapy is to increase the amount of dopamine readily available within the CNS and to reduce cholinergic activity. This can be achieved either by administering a dopamine agonist or by inhibiting the enzymatic breakdown of dopamine in the CNS by monoamine oxidase, B, MAO-B, or catechol-0-methyltransferase, COMT. Drug therapy is, however, limited by severe side effects, nausea and confusion, especially in the elderly. Up to 20% of patients will remain unresponsive to drug therapy. Dopamine is administered as a prodrug, such as levodopa, to allow it to cross the blood-brain barrier, and must be administered with a dopa decarboxylase inhibitor such as carbidopa. To prevent peripheral metabolism, anticholinergic drugs are used when symptoms are mild and tremor predominates, and can be useful in drug-induced Parkinsonism. Preoperative assessment. Patients with PD have high perioperative morbidity and mortality, as well as an increased length of stay. In addition, the complexity of the timing and administration of drug therapies necessitates a multidisciplinary approach during the perioperative period, including from a PD specialist. Important points: a history of dysphagia or excessive salivation, sialorrhea, is suggestive of upper airway dysfunction and indicates any risk of failing to protect the airway during the perioperative period. This may manifest as aspiration, laryngospasm, or postoperative pulmonary complications such as infection. Respiratory function may be further impaired by rigidity and bradykinesia, as well as sputum retention. Cardiovascular instability can result from arrhythmias or orthostatic hypotension 2 degrees to the disease itself or as a side effect of medications. The management of medication administration must be clear and appropriate preparations made to be able to source and administer the drug. Where enteral medications cannot be given, substitutive parenteral therapy must be instigated. The patient should be warned that, even with extensive planning, perioperative management of their Parkinsonism may not be optimal and distressing symptoms may recur. Delirium is also common, with reported rates as high as 60%. Drugs to avoid. Several drugs commonly used in the perioperative period are contraindicated in PD as they can significantly worsen symptoms or cause harmful interactions. Antiemetics, prochlorperazine, droperidol, metoclopramide, antagonize dopamine and exacerbate symptoms. Pethidine interacts with selegiline, which can lead to serotonin syndrome. Synthetic opioids cause presynaptic inhibition of dopamine and cause dose-related muscle rigidity. Clonidine can cause profound hypotension by enhancing the relative hypovolemia. Conduct of anesthesia. Medications for PD should continue uninterrupted until the start of anesthesia. Distressing symptoms may develop as little as 3H after a missed dose, and acute withdrawal of drugs may precipitate symptoms resembling neuroleptic malignant syndrome. Premedication. Consider anxiety-alagogue premedication in the presence of significant sialorrhea such as glycopyrronium, 200-400 micrograms IM. Aspiration risk. Patients with PD have a high incidence of dysphagia, gastroparesis and gastroesophageal reflux. Consideration therefore should be given to securing the airway with RSI and intubation. Airway difficulty, fixed flexion deformity of the neck can occur. Anesthesia technique, general anesthesia with RSI. Regional anesthesia has advantages for those with a difficult airway or significant respiratory or cardiovascular complications. It also allows a rapid return to oral intake. However, muscle rigidity and tremor can interfere with positioning. Surgery and monitoring in the sympathetic blockade can exacerbate autonomic dysfunction. Hypotension is common and can be difficult to treat. Domperidone, which does not cross the blood-brain barrier, may be used safely. If dysphagia will prevent administration of oral analgesia, an NGT may be required. Muscle rigidity may result in the patient being unable to operate. Patient control-led analgesia. For prolonged procedures, administration of dopaminergic medications through an NGT may be necessary. Postoperative care, a restoration of anti-Parkinsonian drugs. Primary consideration is restoration of dopaminergic therapy to prevent an exacerbation of symptoms or an acute withdrawal syndrome. Withdrawal syndromes in Parkinson's disease. 1. Parkinsonism hyperpyrexia syndrome. This follows an abrupt withdrawal of levodopa and resembles neuroleptic malignant syndrome with rigidity, pyrexia, autonomic instability and impaired mental status. It is treated by reinstigating dopaminergic agents and has a high mortality if untreated. 2. Dopamine agonist withdrawal syndrome. This condition manifests with neuropsychiatric symptoms, including depression, fatigue, irritability, diaphoresis and orthostatic hypotension. Patients with advanced disease should be considered for admission to critical care due to the high risk of potential complications, if prolonged GL dysfunction is anticipated postoperatively, such as following emergency laparotomy. Parenteral antiparkinson therapy must be instigated. This can be commenced relatively easily with the use of retigadine patches or apomorphine infusions more difficult to dose, however, and highly emetogenic. Dosing of retigadine. Take advice from a specialist in the management of PD for conversion of enteral medications to transdermal retigadine. In an emergency, or if specialist help is unavailable, dose equivalence calculators are available online at special considerations. Implantation of deep brain stimulators is increasingly being performed in patients with advanced disease. Should the patient then require further unrelated surgery, standard precautions for implantable devices should be used, such as using bipolar diathermy. The device should be turned off prior to anesthesia and checked postoperatively. Postoperative delirium is common in patients with PD and may be delayed. A thorough assessment should be made for potential triggers such as hypoxia or urinary retention. Non-pharmacological management, such as orientation measures, are preferable to pharmacological treatment. However, if required, low doses of benzodiazepines or quetiapine can be given. Dopamine antagonists such as haloperidol must be avoided. Acute spinal